Welcome everyone to King's Health Partners Primary Care webinar series. We're now in our third year and this is the first of 2022. My name is Rachna. I'm a GP in South East London and one of the joint directors of clinical strategy at KHP. If I could ask you as you come into the room to please keep your videos off and your mics muted. Thank you. Today's webinar is on a really interesting topic. It's on how we can help to get the best possible outcomes for the people that we look after who are older and have multiple morbidities or are older and are frail. And we've got a lovely team who will be talking us through the different strategies that they use and that we can also use to do that. Before we get started, just a couple of things. We have a new website where we are hosting a calendar with all of the primary care related events and teaching sessions that King's Health Partners and our partnership hospitals create. So you're very welcome to go there, and we'll pop the link in the chat in a minute. And there's a calendar there so that then you can sign up to events such as these in the future. And in terms of future events, we have a webinar coming up at the end of April on primary care access, a bit of a hot topic. And we also have a maternal medicine course, actually the first that we've ever hosted, happening at the beginning of May. We'll pop the links into the chat for you in a moment. As with all of our webinars, if it's all right, please do give us some feedback. So we'll send you a survey at the end. Our webinars are recorded so you can watch them later, and all of the slides are shared afterwards as well. So without further ado, I would like to please ask Dr. Jugdeep Dhesi to come onto the screen. Jugdeep, thank you so much. Jugdeep's a consultant geriatrician at Guy's and St Thomas's. She's the clinical lead for POPS, the perioperative medicine for older adults undergoing surgery service, and we're going to hear all about that in a moment. She is also Vice President for Clinical Quality at the British Geriatric Society, and will be giving us an overview today about the POPS service, the outcomes that they've achieved, and a little bit, I think, about how we need to make all of this much more seamless for our patients between community and secondary care. So over to you. Thank you, Jugdeep.
Oh, thank you so much, Rachna, and thank you for the invitation to speak at this event. So I'm just going to share my screen, so just bring that up there, and hopefully that is all working okay. So really kind of, 15 minutes to kind of illustrate some of the work that's been going on both locally and nationally around improving outcomes for older people. And of course, this is a webinar for primary care, but hopefully this is going to be the first of future events. And seeing as it's the first of them, I wanted to really give an overview to kick off with, and then hopefully in the next kind of future events, we can start to delve into some more of the detail that we can work on together across primary, secondary and community care services. So I'm going to go fairly speedily, but I think we should always start by recognising the fact that we have had real successes in health and social care, such that we see our population living longer and we see them living healthier. But of course, we know that the 20 odd years lived beyond the age of 65, about half of them are lived with health related problems. And that's not surprising because, of course, everybody has a physiological decline with aging, such that a fit 80-year-old isn't the same as a fit 30-year-old. We know that aging is associated with geriatric syndromes such as frailty and cognitive impairment. And of course, aging is associated with multi-morbidities, such that the average 75-year-old here in our local area in Lambeth and Southwark has at least 3 coexisting conditions. And many of these conditions tend to be degenerative disease, neoplastic disease, metabolic disease, which invariably require surgical intervention, either for symptom control or for longevity. So certainly in primary care, you'll all be used to seeing people like Doreen, a 74-year-old living alone with not much social support, labelled as being a difficult historian, some osteoarthritis but not ready for surgery, some suboptimally controlled but not awful diabetes and hypertension, shortness of breath, not quite sure what's been causing that, maybe some deconditioning, and then maybe presenting with anemia, and could then be going ahead with any of these types of surgeries in the elective setting, or maybe presenting as an emergency as well. And so what happens to people like Doreen? Well, we know that a proportion of people like Doreen decline surgery for the reasons which are stated there. In other cases, may be referred in for a surgical consult and then go to preoperative assessment where these issues are picked up, may be referred back to the GP for optimization, or being referred on to multiple organ specialists to try to address these issues, or comes in actually on the day of her surgery and gets cancelled for these types of reasons. We also know, of course, that a proportion of our patients, a significant proportion, proceed with surgery, and they may proceed having prehabilitation programs, as has been now established at Guy's and St Thomas's and across the sector, and proceed on what are called enhanced recovery programs, where we're pulling together evidence-based approaches to the immediate preoperative, intraoperative and postoperative period, and doing really well in theatre, going to a high dependency unit afterwards for the first 24 hours and doing well there, and then returning to our surgical wards, where of course the majority of care is delivered by surgical juniors. And we know that patients with uncontrolled pain preoperatively are more likely to require higher doses of opiates postoperatively. With guts affected by small vessel disease from diabetes and hypertension, more likely to develop ileus and postoperative nausea, ending up on and off a sliding scale for the diabetes, getting a bit dry, having some fluids, the fluids diluting down that anemia even further, then given some blood, getting overloaded from the fluids that we're giving. So then the juniors think we ought to offload people, give them some diuretics, drop their sodium a bit, develop a bit of delirium, gets labelled as being depression, apathetic, ending up on some antidepressants. And whilst this is all happening, tied down to various tubes and drips each day of the week with underlying sarcopenia such that they functionally decline and then require rehabilitation or increased care in the community. And then we hand them over to primary care to kind of manage the aftermath of this. So with that pathophysiological profile, it's no surprise that the majority of our patients who are in the high risk group for perioperative care are older. And we know that older people are at higher risk of clinician reported, patient reported and process related outcomes. And of course, this is a numerical problem, as you'll all be well aware, twice as many people aged over 65 having surgery now compared to those under 65. And this is, of course, even more of an issue now post our COVID pandemic and all of the impact that that's had on late presentation and deterioration in the community whilst waiting for intervention. So when we think about this and we think about the factors contributing to poor outcome, we often do get tied down in the complexity of the patient and the complexity of the pathway. But I think some of these other factors are also really important to consider when we're trying to improve outcomes. And we'll go through some of these in the next 10 minutes or so. So addressing that complex patient with that complex pathophysiological profile, it needs an underpinning methodology. And again, these are the kinds of things that in primary care teams are very used to managing in terms of screening for underlying issues, diagnosing unrecognised disease, but then importantly, optimising across that pathophysiological profile so then we can plan whether surgery is the right thing or not. And if it is, how do we plan the perioperative pathway and where should that hands-on care be delivered and by who? And of course, every one of those stages being underpinned by shared decision making. And again, to primary care and to geriatricians, this sounds really familiar because, of course, this is looking at multiple domains, using objective tools and multidisciplinary interventions to assess and optimise across medical, functional, social and psychological domains so that we really have got people into the best possible situation prior to embarking on a surgical intervention. So that sounds like comprehensive geriatric assessment to many of us. And of course, we know that this has a very strong evidence base now, both in community-based settings, in primary care settings, and also in medical inpatients. And this kind of numbers needed to treat of 13 being pretty impressive, really, when we compare that to so many other interventions that we undertake in medicine. So it's CGA that we've used in the POPs model at Guy's and St Thomas's. And this is a basic kind of schematic illustrating how we identify patients for our service through both the elective pathway and also how we pick patients up through the emergency admissions as well. And I'll just kind of talk through exactly what might happen in that pathway. So this can, of course, happen both in the elective and the emergency setting. But if I focus on the elective setting, preoperatively, we'll be assessing not only for the known medical conditions, but also identifying undiagnosed issues for lots of different reasons as to why things go missed in older people. And we find that in our service that 2 out of 3 patients receive at least one new diagnosis when they come to clinic. So lots of missed things out there. But then once we've identified them, it's about optimizing them in a one-stop service where we're addressing that multimorbidity and putting into play our general medical skills in terms of managing diabetes, heart failure, Parkinson's disease, things that geriatricians are quite used to managing without referring on to multiple specialists. And again, you can see here how 3/4 have medicines stopped, started, changed during that consultation. Half of our patients have lifestyle interventions, whether that's around alcohol, smoking, physical activity, and then employing therapy interventions to address things like falls and functional status. But of course, that also then feeds into preoperative shared decision making. Once you really know what the benefits, risks, alternatives are to a procedure, then we can think through what the patient would choose to happen in this particular scenario. And we find that about 1 in 7 patients who've already been listed for a procedure actually choose not to go ahead after having had this thorough review of all of the things that matter to them. But for the patients who are coming in, the other things that happen is the actual planning of the perioperative period, making sure that people who should be having day surgery really do get day surgery. So lots of patients with diabetes or dementia get declined for day surgery because they're felt to be too complex, but actually it's the best possible thing for them. But even down to, which wards patients should go to, which day of the week, because of course we don't want complex patients being admitted on a Friday when we don't have the right staff around at the weekend. And then the post-operative management, which of course figures really heavily with the emergency admissions as well, where we're proactively looking for medical complications and addressing them using an evidence-based approach, and then employing our skills in rehabilitation and timely and effective discharge out to the community, and hopefully ensuring that we're having better communication back out to the community to address the longer term issues for individual patients. So that kind of illustrates a little bit about how the pathway works, but does this actually work? It makes kind of sense when we talk it through, but what's the evidence for it? So locally, we have had evidence through each year submitting business plans to support the growth of this service, because this now covers all surgical subspecialties at Guy's and St Thomas's, and both emergency and elective pathways. So there's that kind of level of evidence. But of course, we need to underpin that with the academic evidence. So we have pre and post studies in orthopedic surgery, moving on to quality improvement work in urology, a randomized clinical trial within elective vascular surgery, and then following on from that, systematic reviews illustrating the benefits of CGA in the perioperative period. So that's now being supported with big data studies, illustrating again through audits such as the National Emergency Laparotomy Audit, how geriatric medicine input is associated with improved outcomes. And certainly when we've looked at the first 4 years of NELA, we've seen that the greatest benefits in terms of mortality have been observed in the oldest cohorts. And so that's really reflective of the collaborative approaches that are now being taken to the care of this patient group. So again, okay, so we've got some evidence, but how do we get it out there? So certainly back in 2014, we only had 3 units doing this type of work. And the common refrain was, we want to do it, but we don't have the money and we don't have the workforce. So addressing this, we've now published a series of business plans which are available for other units to look at, illustrating how this is cost effective at a trust level. But we've also published an academic piece of work demonstrating the health economic benefit of this to the NHS as a whole as well. In terms of the workforce, we'll be hearing more about this both from Jason and from Jessie. We've been establishing new programmes to support the education and training of the workforce, looking at allied health professionals that Jason will be talking about, FY programmes for our junior doctors, specialist registrar programmes, and Jessie will be talking there about some of the work that she's been doing within primary care, and then of course some national programmes too. So we are seeing that translation can happen, and there's been an increase in the number of units now delivering this type of work. And we're now supporting that through a national NHS Elect network, where we're providing other hospitals with the toolkit, including all of the clinical resources that we've developed over the last 18 years, but supporting that with coaching and mentoring for those units, and then also support with measurement for improvement. And I think what's exciting for this, of course, that it's happening on a national level, and we've got a really great geographical spread amongst those cohorts. But particularly for us here today, we're making sure that we're setting up similar services, supporting teams at these hospitals to set up the same approaches so that we have consistency of both quality of care, but importantly, access to care as well. That all moves us on to the final bit of that little diagram, which is the need for culture and policy change. And this is where we've been working with national organisations to make sure that the voice of older people and those looking after that group of patients is heard, and making sure that they feature in all of the national reports that are coming out. And that's been really exciting to see that type of collaboration. And that's really being reinforced through the Centre for Perioperative Care, which is a cross-college collaboration, and you'll be pleased to see the RCGP there, making sure that we're looking at this as a whole patient pathway approach, as is illustrated by the underpinning kind of methodology being taken by CPOC, showing here how we're starting with the primary referrer in this pathway and ending back with the primary referrer as well, so that we're really making sure there's that whole pathway approach. And we've recently published our frailty guidelines through CPOC and the BGS, which will give lots of useful resources, both for commissioners and providers, but also for clinicians, with very clear recommendations about what should happen at each stage of the pathway. And these are just a list of some of the pieces of work that CPOC has been undertaking to address each aspect of the necessary work to improve outcomes for older people having surgery. So hopefully in the last kind of 15 minutes or so, I've kind of illustrated how we are taking an approach to each one of these factors, both at a local level and across our sector, but also with some of the national work that's going on. And hopefully that set the scene for Jason and Jessie to be talking about things from their perspective, and will hopefully generate a lot of discussion. Thank you, Rachna.
Thank you so much. I knew about your service, but clearly didn't know about all the intricacies and the background and everything. I have some questions which I will definitely ask you later, but thank you so much. We're now going to move on to our next two speakers. First, we will have Dr. Jessie Colquhoun, who's abroad at the moment, has kindly created a video for us. She was a GP in South East London and was involved in a survey around GPs' attitudes and beliefs towards perioperative medicine for older adults. So we'll have her video on first, and that will be followed afterwards by Jason Cross, who's an advanced nurse practitioner who's also abroad and very kindly done a video, but both of them will be around for the Q&A, and his presentation will be on workforce development within the POP service. So if I could please ask for the first video, thank you. We'll go on to Q&A. Please do pop your questions in the chat. Thank you very much, Sarah.
Hello, my name's Dr. Jessie Colquhoun, and I'm a GP that's been working with the POPs team. I first wanted to discuss the survey that we've had published, and then I wanted to talk about some practical pointers about how to manage these patients in a clinical setting. So first of all, the survey. This is a national survey of GPs about their attitudes and experiences of perioperative care for older adults, and it's the first survey of its kind. So we sent the survey out to just over 700 GPs and GP trainees, and we received 230 responses. What did we find? Well, first of all, 84% of respondents believe that preoperative optimization of older patients improves post-operative outcomes, which is really essential for the whole talk. The role of the GP specifically here, 87% of respondents felt they had a role as a gatekeeper, and 85% felt they had a role in modifying risk factors, discussing modifiable risk factors. Unfortunately, the survey also highlighted some of the areas that really do need some work. So it's clear that GPs feel very undervalued. Only 37% of respondents felt that they had an important role in the surgical pathway, and only 24% felt that they had their assessment and evaluation valued by secondary care. Talking about shared decision making, and we're going to discuss this a little bit further on, using the benefits risk alternative doing nothing, or BRAN model. Benefits, risks and alternative were generally discussed in a consultation, but doing nothing was discussed in less than 50% of the consultation. I think overall, all of these areas were limited by knowledge, which is, very understandable that we can't keep up to date with all of the surgical procedures that our patients might possibly have. And certainly in the comments, we saw that lots of people felt that they weren't always aware of the risks associated with certain procedures, and that this part of the consultation was difficult. So we can talk about strategies around that. Talking about communication with secondary care, overall it was poor. So 64% of people said that the decision about surgery was not clearly communicated, and there was also frustration in some of the respondents, saying that with the little information that was relayed, it was difficult when the patient came back to discuss this, that there was not much information to base the discussion on. Equally, 73% said the alternatives were not clear in the correspondence with secondary care, and 88% of respondents said that the plan for preoperative management wasn't clear. Overall, 50% of respondents said that they had no access to perioperative services across the country, and only 12% of respondents said that they had adequate training, and those are probably going to be those that had a background before that in either surgical or anaesthetic specialties. So going on to practical pointers, the first key message is to say that the perioperative journey starts from the moment it's first discussed, the surgery is first discussed. So that's often going to be in the GP setting. And it's a whole pathway approach. So that's from primary care to secondary care and then back to primary care again. And primary care is essential, especially with such long waiting times for surgery. Unfortunately, the current model for perioperative management just doesn't fully harness the expertise of primary care clinicians in either optimizing chronic disease or in promoting the patient-led behavior change. But perioperative optimization does align with a lot of work we're already doing. So with that in mind, I wanted to just discuss the 3 practical pointers going forward. So Shared decision making, we've discussed this briefly in the survey results. This really works when it's done well. And patients who are active participants in managing their healthcare have better outcomes. In shared decision making, you have two experts. You have the clinician, who's an expert in the clinical aspects, and you have the patient, who is an expert on themselves. So that's on their social circumstances, their attitudes to their illness, what is important to them, and what is an acceptable level of risk. And a key part of the clinician's role is to help the patient to navigate through those key questions, to help them understand and articulate their own concepts of risk and harm, and to help them articulate what they hope to achieve from a potential surgery. And you can do this with BRAN, which is the model we've mentioned just before. So benefits, risks, alternatives, and doing nothing. This can reduce surgical regret. It increases the patient's sense of ownership around their clinical condition, and can lead overall to much better outcomes. There's a leaflet that I really like from the Choosing Wisely website, and I'll leave a link at the end of the talk. I really like this leaflet because patients can fill it out, or you can fill it out with the patient if you have time, and it's useful to generate a question list that they can take to the surgical or the preoperative consultation. And the other thing that can really help with time and also with those knowledge gaps is prescribing a decision aid. So there's a few really good resources for decision aids. One of them is the NICE decision aids, and here on the top right you can see an infographic from a NICE decision aid. Very visual, it's clear, plain language, and they're not too long. They go through many different types of common surgery. Sheffield University has developed a knee and hip replacement decision aid where you put in your own data as a patient, and it answers the question, how much better will I be after surgery? And it puts that on a barometer, and that's a very useful tool as well. And then finally, the third decision aid I wanted to mention was the Fitter, Better, Sooner toolkit, which is from the Royal College of Anaesthetists. And that's aimed at preparing patients physically and psychologically for surgery. And it discusses ways that patients can optimize their health to improve their chances of a good recovery. There's a useful checklist, which includes things like remembering to take hearing aid batteries, and discusses other ways to prepare, including how to get the home ready for post-op recovery with stocking the fridge and other things. And it also has a question list that can be taken to the perioperative team. There's also 6 procedure-specific leaflets for some of the most common operations. And I think with shared decision making, one of the really important things is the language we're using. So I like to talk to a patient mentioning that we can refer for a surgical opinion, rather than saying, I'm going to refer you for surgery. I think this helps to show the patient that it's not a given that surgery is going to take place, and helps to keep ideas about potentially going forward realistic. The other thing I think is just to start with open questions in order to help to keep the patient at the centre of the consultation, and to best elicit what it is that the patient wants. So how prepared do you feel you are for an operation? And you can use this on a scale. That's often very useful, especially with follow-up, because you can go back and say, well, 6 months ago you said you were, say, 5 out of 10 prepared. How prepared do you feel you are now? And what do you think you could do to improve your health in preparation? And how can we best support you to do this? These are some of my favourite questions to use in this kind of consultation. The next point to mention is the CGA within GP, what to focus on and how. So the first thing to mention is that we need to recognise a frail patient. It's important to identify those with frailty or at risk of frailty as early as possible, as this can improve outcomes later on, and it helps the whole perioperative team to prepare. The Rockwood scale is one of the most widely used scales for assessing frailty, and that's a 9-point scale with images that go with it, and it has to be used within the context of a comprehensive assessment for the patient. So it goes from number 1 being very fit to 9 being terminally ill, and it's very easy to use, and it complements the electronic frailty index, which most patients, if they have frailty, will have already in their clinical notes from primary care. A really useful extension of this for people who are less familiar with using the Rockwood scale is the classification tree, with extra questions about patients' ability to carry out activities of daily life and chronic conditions. And this just makes it a little bit more focused and more accurate when you're assessing the patient, making it less likely that you're going to make mistakes about which level of frailty a patient has, which is important going forward when communicating with secondary care and deciding what level of intervention might be appropriate. And then what should we be focusing on? So here are 7 areas that are proven to reduce complications. Of those, just to go through a few key points. So stopping smoking by just for 8 weeks is shown to produce a big benefit, but even just 2 weeks before can also show an improvement. With exercise, I think here it's important to be specific and tailor the advice to the patient, thinking about the 150 minutes a week that we should all be having, so roughly 21 minutes a day. Try and look at what realistically the patient is doing and seeing if they're going to engage in improving their activity, whether that's increasing their walking speed so they can walk as briskly as they can for that period of time, or finding another meaningful activity that they're going to enjoy and adhere to. It's worth helping the patient to understand the benefits of exercise, so that it can improve lung function, it can reduce inflammation, which helps with wound healing, improves appetite and therefore nutrition, and it's also good for cognitive aging. There's 2 resources that I really like with discussing exercise for patients. One is a website called How Fit Today, which has a strapline, Small Steps to Feeling Good. And it's a website that was set up by a geriatrician in the northeast of England with older adult population in mind. And then there's the Versus Arthritis website, which has exercise with people with arthritis in mind. So those with joint restrictions and with pain. With nutrition, I think we should just start with the general advice that we are giving all of our patients. So a balanced diet with 5 a day, and mentioning that vitamin C is good for wound healing, and to make sure that there's a good amount of protein within that balanced diet. This is a good opportunity to look out for any patients who is malnourished or at risk of being malnourished, whether there's any sign of sarcopenia, and getting the MDT involved at an early stage there. It's important to note here that it's going to work best if the patient understands that getting fitter now is probably going to mean that they get better quicker after surgery. And I think if they understand that, then they're going to be more motivated, and our intervention is going to help much more. This list, combined with the use of the Rockwood scale, should be used to generate a problem list. This is going to help to focus the consultation, and it acts as a useful summary, and it's really useful for follow-up, because then you're going through the problem list and working out what can be done and what has been achieved so far. And then finally, follow-up. So supporting patients with follow-up is going to be a really key part of making sure that these lifestyle interventions that patients are willing to undergo might actually work going forward. So it also helps to continue the CGA process, which is an ongoing cycle. And with long waiting times, it's possible that there is a change in patients' wishes or in their condition. So that's either a deterioration or an improvement. So it's important to reassess, and this means that follow-up is essential. And then finally, this is a list of resources that I've mentioned in the talk. And now I'd like to hand over to Jason Cross, who's an AMP working with the POPs team. Thank you.
We're just going to have one more video, which will be by Jason Cross now, and then we're going to have a Q&A straight after.
Hello, good afternoon. This is Jason, nurse practitioner in POPs at Guy's and St Thomas's. Apologies for not delivering this in person. I'm selfishly in sunny Palma away from my wife's birthday, but I do hope to dial in for the question and answer session after my presentation, which is POPs workforce development. And before we start, it's probably worthwhile us just recapping what the problem is. Now, if I was doing this talk 10 years ago, probably what I would be suggesting and what was done at the time would be the NHS would throw more money and throw more staff at the problem. But that isn't going to happen now, and we know the reasons why, but money is in short supply. What we know is that there are training gaps across the whole of the perioperative pathway. A lot of the disciplines involved, the nurses, the allied health professionals, the medical staff, they don't have the specific skills to fulfill the extra responsibilities and roles that are required. So to solve this, we probably need to upskill our current workforce. But more importantly, there's an opportunity to recognise previously untapped expertise that has been there all along, but we've not utilised. And when thinking about the expertise across the perioperative pathway, looking at the Royal College of Anaesthetists perioperative medicine team, you can see that it includes the anaesthetist, surgeon, physician and nurse. But what it didn't include was primary care, which wasn't an oversight at the time. I think only now do we recognise that the perioperative pathway starts in primary care, that early shared decision making, that decision to propose that somebody goes forward for surgery. And with this recognition comes opportunities. And as Jessie's talked about, GPs are willing to be engaged in the perioperative management of their patients. They have expert knowledge in condition management. But these opportunities also extend to maybe improving the communications between secondary and primary care, but also maybe incorporating existing staff to help fulfill our workforce gaps. So this does bring us back, doesn't it? So what skill set is needed if you want to be a perioperative medicine specialist? What do you need to be able to do? Well, what we do know from our experience is whole pathway expertise. So an understanding of the perioperative process, the perioperative medicine process, from the beginning to the end. There needs to be knowledge and skills in comprehensive assessment, whether that be a holistic assessment within primary care, whether that be comprehensive geriatric assessment led by a geriatrician or maybe another medical specialist. But also you probably need an aspect of case management as well, some ownership of the patients that you're treating. So these are some of the questions that are often thrown to us. Do we need a new perioperative specialist? Do we upskill the staff we have? Or, most likely, do we need a bit of both? And when looking in secondary care at the staff groups that you may be able to utilise to support your workforce, there's lots of options out there. But what we focused on at Guy's and St Thomas's are using nurses to enhance our team. And this is because nurses come with a good understanding of holistic assessment. There's a recognised career pathway with regards to advancing clinical practice with some of the ACP pathways and master's degrees that's out there. And there's also an evidence base already, albeit not in surgery, regarding the benefit of having advanced clinical nurse specialists leading on care in earlier discharge from hospital and affecting hospital readmissions. But before I talk a little bit more about nurses, I think it's worth asking the question, who in primary care are we missing out? Are there untapped resources? Are there within primary care and the community that we can integrate with or involve earlier in the perioperative journey. Can we engage with community outreach teams, social prescribers to start some of the interventions, integrate with patients, some of the optimization that traditionally starts when they come into secondary care. The answer to that is I don't know, and maybe you can tell me. I know from speaking to my lovely practice manager wife that there's extraordinary pressure on primary care to meet its targets regarding quality outcome framework and KPIs. So it may be a bit too much to be putting it all on primary care. But is there a way that we can integrate with some of these other members of the community teams to enhance our perioperative medicine team further? I said I would come back to talk about how POPs at Guy's and St Thomas's and other centres have integrated nurses into their expanding workforce. We have a number of nurses, all from different backgrounds, bringing different skills into the team. The way we allocate them, they're allocated to a surgical specialty, which allows them to embed into those surgical teams, but also provides continuity of care. Often those nurses have seen the patients preoperatively, and they get an opportunity to observe and influence their care throughout the pathway after surgery and then to discharge. Their education and upskilling is supported by robust clinical governance, but has also allowed us to design a capability framework focusing on the development of a junior nurse to a senior nurse in POPs. And this is drawn from our experience, and we haven't kept it just in-house. We now share this with a number of initiatives, one being the POPs network. Through NHS Elect, we've started a Southeast region network for clinical nurse specialists of all levels to help provide clinical supervision, troubleshooting and upskilling of knowledge. And then we're in the process of applying to the South East London Cancer Alliance for a practice development nurse or a practice development practitioner to formalise this clinical supervision and standardise education for the clinical nurse specialist group. And then we've also taken the capability work a step further and designed an in-house 2-day nurse and allied health professional module looking at the care of the older patient who's undergoing surgery. And this is supported with learning outcomes and links directly with some of the excellent work done by the British Geriatric Society, and there's an online module together with a 2-day course which we've successfully trialled in 2019, and we hope to run a second cohort later on in this year. And then, just because it appears I'm a glutton for punishment, we are in the process of quite far on in the process with London South Bank, looking at a MSc programme in perioperative care, again open to anybody, so nurses, allied health professionals, medics, and that will cover the 4 pillars of advanced practice. And so somebody will do this MSc in perioperative care and be a qualified advanced clinical practitioner. And in conjunction with that, there is some work done with the Royal College of Physicians in Health Education England, looking at core competencies and a capability framework that's in progress and relatively advanced as well. So hopefully looking to develop not only local but national resources to help upskill our workforce in perioperative medicine. Now, my last few slides have obviously focus very much on education and secondary care, but what I'd like to do is bring it back to primary care and the opportunities that now we're faced with, and it's really exciting. if we can start building those bridges, improve communication between secondary and primary care, we can start influencing that patient optimization earlier in the pathway. We can look at shared decision making, and instead of restarting that when somebody comes to secondary care, but we can carry on those shared decision making discussions that have already started with the GP. And I really do think it's an excellent opportunity to maybe start thinking about the workforce differently. You know, we should be harnessing the community and primary care workforce. You know, they have the skills. We have the opportunity to make the pathway a lot more efficient and save some money. And with that in mind, I'd like to just kind of talk a little bit about the work I've recently been doing at Lewisham. So in our meetings with primary care and the multidisciplinary team in secondary care, three things kind of stand out, three themes. GPs want specific advice on issues, not generic letters that say so-and-so's blood pressure is poorly controlled, poorly optimized. And they want documents with primary care in mind, or, you know, so information is easy to access. But also they want a single point of contact or somewhere to go should they want to get advice on all manner of subjects relating to primary care. And Jessie probably touched on this, but this is a POPs clinic letter from a pilot I've recently run at Lewisham. And as you can see, it's a long letter, our POPs letters, but this is page 1, you know, right at the top of the letter are the actions for the GP, highlighting issues that need to be addressed with clear advice on what needs to be done. And then another bit of work, which is at the moment being discussed with the anaesthetists and GPs in our meetings, is around how we communicate when a patient is placed on a waiting list. And here's some very clear guidance which draws on the evidence base around what is acceptable for a blood pressure, level of diabetes and HB preoperatively, and what we envisage is this will go back to primary care when a patient is listed. So that time between listing and surgery, we can be proactive in the management of these conditions to reduce cancellations. So my final slide, and in summary, I think, yeah, given our limited resources, upskilling of our existing workforce is a priority, and there's already a lot of work that's going into education and resources to help that upskilling. There's a possibility that other professionals may have skills needed already to bridge the gap, and I wonder whether that is with primary care, with our social prescribers, our community teams. But it's obvious that we do need better integration of primary care, and there needs to be dialogue between primary and secondary care to create the tools that are essential in the transfer of information and optimization of patients as early as possible within the perioperative pathway. I thank you. I look forward to taking your questions. If you want to contact me via email, then do so at jason.cross@nhs.net. Thanks again. Cheers.
Thank you very much. If I could please invite Jason, Jessie and Jugdeep to come onto the screens and unmute. We'll get on with the Q&A. Thank you so much. And thank you so much, especially Jason, and happy birthday to your wife from us all.
Thank you.
No, not at all. Please do pop your questions in the chat, but I might just get going with some of mine in the meantime, if that's all right. So just a point to clarify, the POP service can be referred to in parallel to a referral to the surgeons, right? It's not one and then the other.
No, that's right, Rachna. It can be both. I mean, predominantly at the moment, near enough all of our referrals come directly from the surgeons. So they see the patients at the initial surgical consult, either do want to proceed or they're not sure whether the patient requires more support in shared decision making, and they make the referral at that point. But we're absolutely very open to receiving referrals directly from primary care at the time of referral into surgery. That may make things a little bit difficult for us because, of course, not all of those patients may be even offered surgery, but from a technical surgical point of view. But those are the kinds of things that we're going to have to test and see how that works, and then refine pathways as we go along.
And at the moment, the POP service in Guy's and St Thomas's covers certainly Southwark and Lambeth. Does it cover the other London boroughs in South East London as well? Or yeah.
So we cover everybody who's referred here for surgery, and of course we get lots of tertiary referrals as well, considering that we run so many specialist services here. So we see many patients from Wales and Scotland as well as our local boroughs. Not just for Lambeth and Southwark.
Okay, and the services starting at King's and Lewisham, Greenwich and Dartford, do we have a timeline for those? Or?
Yeah, so the Dartford and Gravesham's already been kind of available for some time now. So Anna Whittle is the lead consultant there. Catherine Malak has been running the service at East Kent in Canterbury for around about 18 months, 2 years now. So that's also been fully fledged. King's and is just coming on, has had a service, but is expanding their service and formalising that. And of course, Jason's doing the work at Lewisham and Greenwich, helping them to set the service up before we get him to come back to us.
Perfect, and actually that's a good segue maybe to Jason. The work that you're doing in Lewisham, how much of that kind of integration, talking about how secondary and primary care can work more closely, how much of that is happening in Lewisham, or that's just beginning now?
That's just starting right now. My initial few months has been to embed and look at the surgical inreach within general surgery. Parallel to that, there's been some work looking at the orthopaedic long waiters, which will feed into some pathway development and a POP style service. We've trialled a POPs clinic, a very short trial of around about 12 patients, just to test the pathway and also just try and iron out some of the issues. So I imagine before the end of this year we should have a recognised kind of pathway for the Lewisham patients.
And just to touch on training, I mean the training that you've developed is really quite comprehensive. There was one bit in there where you talked about training for nurses that can upskill in perioperative medicine. Is that open to primary care nurses who are based in primary care?
Absolutely. So we trialled the 2-day module, 2-day course a couple of years back, and at that time we had other allied health professionals also joined, so physiotherapists, occupational therapists. The feedback was very good. My expectation is when we do start running it, and we're running it regularly, and we hope to do it a couple of times a year, that we will be taking anybody who wants to come along. So that could be your social prescriber or your care coordinator in primary care who wants a more of an overview around kind of perioperative medicine, some of the conditions, some of the condition management.
Perfect. Well, we'll be happy to circulate that when that happens. I did notice in your letter, which looks very comprehensive, and I'm sure Iram Patel, who's on the call, will back me up. It'd be lovely to have a Vital 5 section in there, which basically you cover within your work anyway, but that was just a thought that popped up to me. If we could maybe move on to risk management, and I was quite struck by some of the stats that you mentioned. So doing a proper assessment increases the chance of someone being alive by 30%. That's huge. You mentioned, Jessie, that someone stopping smoking even 2 weeks before their procedure can make a difference to their outcomes. Can we just touch on maybe that last point first, if you don't mind, Jessie?
Yeah, absolutely. I think when you go with this long list of things, recommendations and lifestyle changes, people get quite swamped, and being specific and giving a timeline really helps. And often people surprise you when you say, if you just stop for 2 weeks, this actually might make a difference, and kind of explain why. I think that, using those interventional motivational techniques that we use in GP all the time, that really helps. I think if you stop just a few days before, can actually sometimes make things worse. Jugdeep mentioned more than me, but from a kind of secretion point of view. So
it's sort of carefully mentioning that it has to be sort of a little bit longer than just a couple of days if they are going to stop. But yeah, there's obviously the longer you can give out, the better. And often people then make that lifestyle change permanently, which is amazing.
Amazing. With regards to risk reduction, I guess, Jugdeep, often we get letters in primary care saying, please get your patient's blood pressure down within a week because their surgery is in 10 days time, or, their anemia is this, please sort it out. What do we do? How do we approach that? What support is there for us?
That's so frustrating, isn't it, getting letters like that? There are very clear guidelines for hypertension in the perioperative setting. So they are on the AAGBI guidelines section, so we can forward those links to the team. But essentially, this is about long-term management as opposed to having a knee-jerk reaction to a one-off assessment in a preoperative assessment clinic where patients are often anxious or in pain or other things that may be impacting on their blood pressure. So every time that we write about blood pressure, we always refer to the AAGBI guidelines, which illustrate that if you've had OK readings in the community in the preceding X weeks, then that is fine, even though it might be high at the time of induction at theatre. But we can send those links out. We are just working on the CPOC guidelines for anemia, which will hopefully give much clearer, easier kind of pathways to follow for everybody along the perioperative pathway. But I think, in most of those situations, it's really useful for us to hear back in secondary care from GPs to say, actually, this isn't helpful, the way that you're framing this question to us. Can you provide us with more explicit instructions so that then we can follow through on that? And I think we just need to push each other to become more evidence-based. There's certainly, a risk of people's surgery being cancelled for non-evidence-based reasons as well. So we do need to kind of avoid those kind of generic letters coming out of preoperative assessment saying, do this for anemia or do that for blood pressure. But I can send those links.
Thank you. And are you available on Consultant Connect? Yeah, okay, also, so we have multiple.
So we're available through our geriatric medicine on-call rotors, which most of us kind of, I think, POPs cover quite a lot of the Connect calls for geriatric medicine. But if you use that and you want to have specific advice, if you ask the person answering to let the POPs team know or to give you any contacts, then we'd be very happy to do that.
And I guess my final reflection in the last minute is how shared decision making is completely at the core of what you do. I don't think I quite appreciated that enough, and I think I'm probably a little bit guilty of not giving it enough attention to the extent that Jessie, you sort of did in your talk in primary care. So I've really learned about that, and I wonder if we revisit that in a future webinar, because I think it feels like it's really important, because you're right, there is always the option for people to say, no, I don't want that intervention, but how do we support them with the right information so that they can make the decision for themselves? I've got a lot of questions scribbled down here. I'll have to ask you a different time. I'm really sorry, we sort of, we packed a lot in, but we're really grateful for all three of you for doing this. Jugdeep, yourself, Jessie, and Jason, of course, dialing in from being away. Thank you so very much. All of the slides will be circulated alongside with our survey. Please do take part in the survey so that you know how to improve for next time and other topics as well for the future. We do have our next webinar on the 27th of April, which will be on primary care access. And we also have a course on maternal medicine, the first actually that we have done, and that's open to everyone, and that'll be happening in May. So please do sign up. We'll send all of those things around. It leaves me just to say a very big thank you to everyone, and especially to the team who of course helped put this together. So Sarah, Jen and Wenda. And if you want to watch this again, it will be on the Learning Hub. Thank you everyone so much. Have a lovely Wednesday afternoon.